Hello, good evening, students. Am I audible? Can you see me? Can you hear me? Hello, good evening. Yes. So, am I audible? So, very warm welcome to all of you to ENT Thursdays. So, I hope you did your homework of studying all the conditions of the neck that we had done. Yes, and I hope you go back and you study whatever we have done. Yes. So, yes, and when you go to the postings, yes, try to see the cases and interpret them yourselves. Try to come to a diagnosis. Try to make differential diagnosis in your mind. Try to come to a diagnosis and think of how you're going to treat that patient. And if you started from now itself, it is going to become very easy. And even if all those who are just preparing for the exam this year, or maybe in the end of the this year for NEET or AIMS, whatever. So whatever you are studying, it has to be you have to be able to reproduce it. You have read a topic, you should be able to think that okay, this is how any patient of this condition, this is the part of the body that I am studying about, this is its normal function, and if anything goes wrong with this part of the body, this is how it is going to present. So this is how the patient is going to come to me, and by his symptoms, how am I going to diagnose him, how am I going to treat him. So only if you do it this way, you will be able to remember it, you will be able to understand it and remember it. So read a topic, try to reproduce it, and try to give your own answers, and then you come back and see how the treatment is. Okay, so let us start. Today we are doing the conditions of the oropharynx. Yes, but we have a few conditions otherwise also. Okay, so let us quickly start. So the first case we have is a 13-year-old male child. Okay, I'll just put on the marker. Okay. So it is a 13-year-old male child who was brought to the emergency department of a hospital in Uttarakhand with the chief complaint of acute onset sore throat for 5 days. Okay, so it is acute onset and there is sore throat for 5 days. There is productive cough for 3 days. There is dyspnea and odynophagia for 2 days. So odynophagia is painful swallowing, and there is difficulty in breathing. There is dyspnea and odynophagia for 2 days. His parents revealed that the pattern of fever had changed from low grade to intermittent to high grade and continuous in the preceding 5 days. He was finding it extremely difficult to swallow both solids and liquids of late, and he had labored in noisy breathing. He was conscious and oriented but looked toxic. He was febrile with a temperature of 102, heart rate was 120, and respiratory rate was 24 per minute. So what is your differential diagnosis? Yes, so just imagine it is a child, a 13-year-old child, male child who has come to you, and all the complaints are of there is difficulty in swallowing, there is pain in the throat, sore throat, there is cough, there is difficulty in swallowing, along with there is some difficulty in respiration also. Yes, and there is fever also. Yes, so fever tells you it is a acute infective condition. So what there is difficulty in swallowing both solids, liquids, and he is looking toxic. The temperature is also high. Yes. So what is your DD? Yes, think of all the DD you can think of. Tell me. Yes, you have to think and tell me. This is how the presentation is given. And when such a presentation is given, you see the presentation and you start to panic. So no need to panic. You know everything. Just believe that you know everything. Whatever is coming to your mind with this presentation, you must be having relatives, friends who complain गले में दर्द हो रहा है, खांसी हो रही है, सांस लेने में भी थोड़ी तकलीफ हो रही है, कुछ भी खाया पिया नहीं जा रहा, दर्द हो रहा है गले में. So what are the things that come to your mind? Yes, very good. Yes, there can be. Very good. I can see answers coming. Yes, there it is an infective condition. Very good. It is an infective condition. It can be acute tonsillitis. Excellent. It can be acute tonsillitis. It can be any abscess. Yes, it can be. Can it be a peritonsil abscess? Yes. Also throat, difficulty in swallowing, difficulty in breathing, and fever, acute onset. So yes, it can be peritonsil abscess. Yes, I can see you are answering it as parapharyngeal abscess. Yes, it can be parapharyngeal abscess. It can be retropharyngeal abscess. So which means that we have any obstruction, and that is an acute inflammatory obstruction of this area, which is involved for swallowing as well as for breathing. So this can be acute membranous tonsillitis, which where the tonsils are so huge that they have completely obstructed and leading to dyspnea. Yes, and did I see? Yes, Rashmi answers it that it can be epiglottitis also. Can it be epiglottitis also? Yes or no? Sore throat, fever, cough, dyspnea, odynophagia. Any difficulty in swallowing? Can it be any condition of the larynx? Any difficulty in swallowing? Yes or no? Yes, which part of the larynx is involved in swallowing? Yes, whenever we swallow, the epiglottis moves down to close the inlet of larynx. So if the epiglottis is infected, swollen, patient will have very severe pain in swallowing. So when you see difficulty in swallowing and odynophagia, don't just rule out that now this cannot be larynx at all. It has to be only the oropharynx. Okay. So if there is any difficulty in swallowing, we can also think of any epiglottic condition. And since it is acute infection, we can also think of epiglottitis. So whenever you think of dyspnea, don't just think that it can be only larynx. Dyspnea can occur because of any obstruction of the airway. That can occur at the level of oropharynx also because of all these abscesses. Yes. So we have so many DD here. Okay. So we have you made the DD of tonsillitis. You made the DD of peritonsillar abscess. You made the DD of parapharyngeal abscess. You made the DD of retropharyngeal abscess. You made the DD of epiglottitis, and yes, you also made the DD. I also see. Yes, very good, Akash. And says that it can be diphtheria. Yes or no? Can it not be diphtheria? 13-year-old male. Is there any history given that shows that it cannot be diphtheria? It can be diphtheria. Can it not be infectious mononucleosis? Yes or no? Diphtheria, infectious mononucleosis, all these present as acute onset fever. And can you tell me, can it not be corona? What do you think? Sore throat, fever, productive cough, dyspnea, odynophagia because of so much of pain in the throat. I mean, see, it can be so many things. Yes, it can be diphtheria, it can be infectious mononucleosis. So it can be a viral infection, infectious mononucleosis, where the tonsils are so hugely enlarged it can lead to dyspnea. Diphtheria, it can be diphtheria. In diphtheria, there is membrane which can obstruct the larynx also, and that can lead to dyspnea. Their tonsils are hugely enlarged, that can lead to dyspnea. The pseudomembrane can lead to obstruction, lead to dyspnea. So all of them present like this. So when such a patient comes to us with a complaint, गले में दर्द है, बुखार है, खांसी है, डिस्निया है, swallowing में difficulty है, there are so many things, all the conditions, the complete picture of the oropharynx comes to your mind, that there can be any acute inflammatory condition of the oropharynx, there can be any acute inflammation of the larynx, of which part? Of the epiglottis part. Okay, so we have so many DD in our mind. Yes, so we have so many DD. Yes, Divya says, no, Anurag says that dry cough in corona. Corona can be any cough. It can be dry cough. It can be, there is pneumonias also na, in corona. So there can be, yes, cough otherwise also. Okay. So we have made so many really excellent. Yes, very good. Vincent's angina. Vincent's angina. Croup. Okay, so Nikhil says, can it be croup? Croup. In croup, is there odynophagia? In croup, croup typically presents, it is mainly involving the larynx, trachea and bronchi and mainly the lower part. So there mainly the patient has cough and the patient will have difficulty in breathing. But the features of odynophagia, when odynophagia comes, then we will rule out croup. Croup cannot be. Yes. So Divya asked me whether it can be a um, okay, so yes, there are so many things coming to your mind now, no? Okay, Divya asked me that can it be agranulocytosis? What is agranulocytosis? What exactly is agranulocytosis? Agranulocytosis means that yes, all the there is neutropenia, there is lymphopenia, all the cells, the inflammatory cells are very less. So how does the agranulocytosis present? Agranulocytosis presents with repeated infections. Repeated infections can be in any form. Yes, so agranulocytosis is a diagnosis that we make on blood, examining the blood on the complete blood count. Agranulocytosis, leukemia, all these present with recurrent infections. So this can be this is acute infection. So these are the if the patient is not giving any previous history, the agranulocytosis, leukemia, all that diagnosis we can make only by seeing the blood picture, not just by the clinical examination. Okay, so Swati asks, can the toxic look rule out viral etiology? High grade fever also rules out viral etiology. Now, see, viral etiology also, high grade fever can be present. Yes, the toxic look goes more in favor of a abscess or a bacterial. But in viral also there can be very high grade fever. In viral, along with, yes, the features are more generalized, but this can be viral also. Okay, so now let us see what the okay. Okay, now we have so much DD and now we are going to examine this patient. So we did the oropharyngeal examination. Oropharyngeal examination revealed the soft palate was congested. Okay, there was a grayish white membranous patch. There were grayish white membranous patches on the medial aspect of both the tonsils. Tonsils were hypertrophied grade 3 and congested. Posterior pillar was not visible. General systemic examination was normal. Okay, so general systemic examination was normal. Investigations are carried out and the result is given here. Result shows hemoglobin is less. TLC is 29,000. How much is normal? Yes, 11. So this is raised. Deranged leukocyte count, neutrophils. See, neutrophils are so much raised. Lymphocyte, monocyte, eosinophil. Okay. So what now have you narrowed down to? Diagnosis. Which diagnosis have you narrowed down to? Surendra is asking me that infectious mononucleosis is viral. Of course, yes. Infectious mononucleosis is a viral condition. It is caused by, yes, can you tell me infectious mononucleosis is caused by what? It is caused by Epstein-Barr virus. Yes. So now tell me what is the diagnosis that you are having. You had so many details in your mind. You have narrowed down to which diagnosis now? Yes, which diagnosis have you narrowed down to and what is helping us to come to a diagnosis? This grayish white membranous patch. Yes, on the medial aspect of both the tonsils. Tonsils are congested, so we are not seeing any tonsils pushed medially. We are not seeing any, if tonsils are not pushed medially, then what two conditions are ruled out? Quinsy is ruled out, parapharyngeal abscess is ruled out. We are not seeing any bulge of the posterior pharyngeal wall, so retropharyngeal abscess is also ruled out. Yes, so if there is a membranous patch on the tonsil, it can be acute tonsillitis. What all can it be? It can be membranous tonsillitis. It can be, yes, now I will not tell you what it can be. You will tell me, yes? Yes, very good, Kunj. It can be diphtheria. And what else? What else? Can it be Vincent's angina? Yes, it can be Vincent's angina. It can be membranous tonsillitis. Can it also be infectious mononucleosis? Yes or no? Infectious mononucleosis, it can be infectious mononucleosis. Yes, so most probably, now just tell me, okay, so you have now narrowed down to either diphtheria, or you are telling me it can be infectious mononucleosis, or what else am I seeing? It can be acute tonsillitis, okay, membranous tonsillitis. You are telling me. Okay, so we have narrowed down to three things. Now tell me that what in this presentation is telling that it cannot be infectious mononucleosis. What in this presentation is telling that this cannot be infectious mononucleosis? This cannot be infectious mononucleosis. Tell me why it cannot be. I am telling you it cannot be infectious mononucleosis. Tell me why it cannot be infectious mononucleosis. I have removed infectious mononucleosis. Anything here is telling you why it cannot be infectious mononucleosis? In infectious mononucleosis, this is a viral, this is not bacterial. Yes, I'm waiting for your answer. I'm giving you all the hint. This is viral. Infectious mononucleosis is viral. This is not bacterial. So, yes, this is not bacterial. This is viral condition. So, what in the picture? Blood picture. Blood picture. Very good. The lymphocytes will be high. Cervical lymphadenopathy will not be present. Cervical lymphadenopathy is present. Cervical lymphadenopathy is a very important feature of infectious mononucleosis. Yes, increase in neutrophil. Very good. There is increase in neutrophil here, which shows that this is a bacterial condition. In infectious mononucleosis, the diagnosis is by lymphocytosis. The lymphocytes are increased. So we have ruled out infectious mononucleosis, and now we have two things in our mind: diphtheria, and it can be a membranous tonsillitis. Yes. Okay, anything else here? Okay, now the patient is very toxic. Okay, the patient is looking very toxic. There is, so yes, more it is going towards diphtheria. So what important history should be taken? What is the important history that you will take? Yes, the tonsils are hypertrophied grade 3. What is the meaning of grade 3 tonsil? Yes, and this is something that is asked also. In your viva, it is asked very commonly, what is grade 3 tonsil? Yes, so tonsils are graded as either one is, you can say it is within the pillar, or you can say 25%. It is occupying 25% of the oropharyngeal airway. Oropharynx, it is occupying 25% of the oropharynx, or it is within the tonsillar pillars. It is inside the tonsillar pillars. It does not come outside the tonsillar pillar. Okay, 2 is when it is 25 to 50%. Okay, so 26 to 50%, up till 50% is very easy to remember. Okay, 25, 50, 75 and complete. And 2 is when it has come out of the tonsillar pillar. So there are two types of grading. One is in percentage, one is in when you are seeing it how much it has come out. Okay, so 2 is when it has come out of the tonsillar pillar. 3 is when it is, what will be next, up till 75. So 51 to 75. Okay, so it is just 25, 50, 75 and it is complete. 4 is complete obstruction. Or 1 is when it is inside the pillar, 2 it is come just outside the pillar, 3 is when it is occupying 3/4 of the oropharynx, and 4 is when there is complete obstruction. Okay, yes, the tonsils, when they are kissing each other, when they are meeting each other, that is what is known as 4, that is complete obstruction. So what important history will you take here? Yes, tell me what important history. Very good. Amruta says a history of immunization. Excellent. That is a very important history that you are going to take, history of immunization. So what is the next investigation and approach? What will be your next investigation? You have already done the blood test, you have already gone the blood test done, and uh, what is the next investigation? Yes, tell me what the next investigation is. History, you have taken history of immunization. Very, very important is history of immunization has to be taken. Yes, will you order for a throat swab and a culture? Yes. Yes, very good. History of immunization, history of contact, and yes, throat culture will be done. Now, this patient you got all that done, and now this patient was started on injection amoxiclav and metronidazole. Okay. However, this condition deteriorated rapidly with increasing difficulty in breathing. He was subjected to emergency tracheostomy and maintained on medical ventilation on the second day after admission. Electrocardiography revealed the ST wave changes. By the time aerobic culture report was released, patient's condition had worsened uh, further. The isolate was confirmed as Corynebacterium diphtheriae on the fourth day of admission. Oxygen saturation of this patient decreased to 18%. Cardiopulmonary resuscitation was started by critical care team, but unfortunately the patient could not be revived. Okay, so this is a Corynebacterium diphtheriae. We had narrowed down to either diphtheria or tonsillitis, and now the diagnosis by the culture has come to be diphtheria. We had started already the management. Yes, the Corynebacterium diphtheriae, it is, yes, gram positive management has to be by amoxiclav, but in spite of that the patient had worsened, and here ECG is also showing changes. Why is ECG showing changes? Does the diphtheria involve the heart? Yes or no? Yes, diphtheria involves the heart. There is myocarditis, there is endocarditis, there are fibrillations, there are conduction blocks which are seen in diphtheria. So myocarditis is seen anytime after first week, or it can be seen in the first week. And there is a very important other complication, and that is neurological complications that occurs after the heart complication. That has been a question that is asked in your exam, that what occurs last to occur is the laryngeal complication, the respiratory complication, or the heart or the nerve. Yes, the neurological is last. Yes, excellent. I can see all of you are telling me what was the mistake in the management. Yes, the mistake was that in diphtheria, the moment we suspect that this is diphtheria, immediately the antitoxin has to be started. Now, in diphtheria, the toxin is the one that leads to everything. Toxin leads to ulceration, and that leads to the fibrinous membrane being formed, which contains bacteria, which contains the neutrophils, which contains dead epithelium and dead blood cells, and this is highly infectious. And when this membrane sloughs off, then it can lead to obstruction, and this toxin that is released into the blood, it is exotoxin, so it can be just in the blood, or it has gone inside the cell. So the one that has gone inside the cell, the infection we can treat by the antibiotic, but the toxin, uh, we need to neutralize it before it binds the cells. Once it has got bound to the cell, we will not be able to do anything. So if we want to stop the progression of the disease, we will have to give antitoxin immediately. The moment you are suspecting diphtheria, you will start antitoxin, and you will not wait for the culture report to come. And do you think that diphtheria is now not seen at all, or are we again seeing diphtheria nowadays? Yes or no? What do you think? The diphtheria has not been completely eradicated because the immunization is given, and nowadays booster is given. Every 10 years the booster needs to be given. So if the booster is not given, even in adults or in elderly, the immunity wanes off, and it is again seen nowadays. Again it has come up, diphtheria. So that is why we need to immediately start the antitoxin, and along with that we give the antibiotics. Yes, so we take the culture now. Tanmay is asking that if we give antitoxin, it will be revealed not to be diphtheria. No, we have already taken the swab. We have taken the swab for culture, and we have started the antitoxin. Yes. Yes, so now diphtheria, because it is re-emerging, this is a very, very important question of your exams. In fact, almost every year now diphtheria is asked. And somebody recently asked me a question also, and that was that some child belonging to some tribe has presented with difficulty in swallowing, sore throat, and little difficulty in breathing, and there is lymph nodes that is seen. So what are the things that will come to your mind, and what history you will take, how will you manage this patient? Yes, so it is very important that when you see the presentation, there should be so many things that should be in your mind, and now how to come to a diagnosis, you should know that. Yes, so now let us quickly come to the Next question. Yes, we are seeing here. This is exactly how the diphthetic membrane looks like. The diphthetic membrane, see carefully, it is not only, does not confine only to the tonsil. It extends outside the tonsil. So wherever the toxin is leading to ulceration, it is leading to the membrane is present all over. It is not localized to tonsil as the other membranes of the tonsil which are localized to tonsil. In Vincent's angina, what is Vincent's angina? Yes, it is gingivitis. There the membrane starts over the gingiva. Yes, and can you see here? This is a typical bull neck appearance. Bull neck. What is bull neck appearance? Yes, there is cervical lymphadenopathy along with edema of the subcutaneous tissue. That is what is the typical bull neck appearance. Okay, so now let us come to the next question. The next question we have here is a 20-year-old male who has presented with fever, a diffuse but okay, so Divya says that I'll just come back to that. Okay, Divya says that it can extend to the soft palate. Yes, it can extend to the soft palate. Not only to the soft palate, it can go back into the oropharynx, it can extend into the larynx, it can cause obstruction. That is why here, did you notice in this question that in this question the management of the airway, the patient was dizzying, the patient had gone into respiratory distress, intubation was not done there. Yes, what was done was tracheostomy, because when you do intubation, then the chances that you will dislodge the membrane and you will put it into the airways leading to further obstruction increases. So tracheostomy is preferred here. Okay, so a 20-year-old male presented with fever, diffuse body aches, sore throat, nasal congestion, difficulty in swallowing. So here also we are seeing almost the same. Yes, there is fever, there is body ache, there is sore throat, there is nasal congestion, there is difficulty in swallowing. He was initially seen 10 days prior by his primary care physician for the complaint of fatigue and body aches. So since 10 days he's been having this fatigue and body aches. Medical history included GERD, gastroesophageal reflux, anxiety, moderate tobacco and alcohol use. He was on no medication. He was a student and worked as a manager of the restaurant. His body temperature was, so he is having fever. Blood pressure is almost normal. Pulse rate has increased. Respiratory rate is increased. So again, tell me, what is your DD? What is your DD? Yes, he is having fever, he is having body aches, he is having sore throat and nasal congestion and difficulty in swallowing. So again, yes, we have all the things that come that we made the DD there. Can be a DD here also: fever, diffuse body ache, sore throat, there is difficulty in swallowing. So it can be either any pharyngitis, it can be any condition of the oropharynx, infection or abscess of the oropharynx, or it can be difficulty in swallowing, it can be acute epiglottitis, it can be diphtheria, it can be infectious mononucleosis. Yes, so again, yes, it can be as simple as just a pharyngitis also. Yes, so are you seeing that when this the presentation, so many things come to your mind, and now how are you going to differentiate? That is, so many things get ruled out when you examine the oropharynx. Yes, so let us see what the examination shows. So the examination shows that the patient was alert, awake, flushed face and spoke with a muffled voice. There was no respiratory distress. Head and neck examination revealed tender cervical lymphadenopathy, and there is erythematous swollen tonsil that were in opposition, minimal white exudates. Yes. Yes, so here the patient has, yes, the orodental hygiene was good, systemic examination was normal except for mild splenomegaly. So we examined, first we examined the because the all the symptoms are confining to the oropharynx. So we examined the oropharynx where we saw that the tonsil was swollen. And opposition, they were in opposition with opposition. So quickly tell me, if there is an opposition, so what is the grade? What is the grade? Yes, the grade is grade 4. In opposition is grade 4. Okay, so yes, yes, Ramesh is asking me, can the fatigue be because of tumor? Yes, will the tumor have any tumor of the oropharynx? Will it have such an acute presentation of fever? Tumors, I mean, if you're asking me if it can be leukemia or agranulocytosis, it can be, but yes, any tumor of the oropharynx as such unlikely, because there is acute onset of fever, diffuse body aches. Now tell me what this very good, but you notice that there is fatigue, there has been fatigue for 10 days. So fatigue for 10 days, and anything does it point out? Yes, you first tell me here, orodental hygiene was good. So again, we are seeing some membrane over the tonsil. So when there is a membrane over the tonsil, what are the such acute presentation condition come to your mind? Okay. Yes, that can be diphtheria, that can be infectious mononucleosis, that can be Vincent's angina, that can be either leukemias, that can be agranulocytosis. Yes, Candida membrane will not have acute presentation of fever. Yes, we know all the membrane of tonsil. We have learned all the causes of membrane of tonsil. Yes, we had a mnemonic for that also. Yes, we have learned that. Now, if we have learned all the membrane of tonsil, now it is not only for just learning and ratifying and answering in the exam. This is how we have to think, that if there is any acute presentation, it cannot be candidiasis, it cannot be a tumor of the tonsil, aphthous ulcer or traumatic ulcers get ruled out if it is a membrane over the tonsil. So we are narrowed to these. And Vincent's angina here, can this be Vincent's angina? Can this question be Vincent's angina? Yes or no? Can this be Vincent's angina? Yes or no? Now, this is, what is the important history that is given here which tells you that this cannot be Vincent's angina? Yes, Vincent's angina. What is Vincent's? I told you how to remember. Vincent's is gingiva. Gingiva. Vincent's is gingiva. Gingivitis is Vincent's angina. Here the orodental hygiene is good, so that rules out Vincent's. So this is not Vincent's. Now leukemia and agranulocytosis we will come to know by the blood picture. Blood picture, is it given here? No, it has not yet been done. Okay, so that is, I think, the next investigation that you will ask for will be the blood picture. Okay, so we have now diphtheria, infectious mononucleosis, leukocytosis, agranulocytosis in our mind. Okay, now let us, okay, there is splenomegaly also. One important feature, there is splenomegaly. Okay, let us now have a look at the finding. You got the investigation done. Hemoglobin is normal. Leukocyte count is okay, normal. Differential leukocyte count shows lymphatic predominance, lymphocytic predominance. Atypical lymphocyte of 11%. Normal platelet count, renal function is normal. Urine examination, normal. Liver function test, mild elevation. Okay, so yes, so now what is your diagnosis? What is your diagnosis? Tell me what your diagnosis is. Now, yes, very good, Surendra. Yes, there is atypical lymphocyte. There is lymphocytosis. And what is the test that tells you about the the antibody? This is infectious mononucleosis. This is caused by Epstein-Barr virus. Yes, the Paul Bunel test tests the antibodies. Yes, so that is the Paul Bunel test. You go for monospot or the Paul Bunel test, or you go for seeing the lymphocytosis and atypical lymphocytes. Atypical lymphocytes more than 10%, lymphocytosis, all that is suggestive of infectious mononucleosis. Okay, so that was the important thing that was given in the history, that this is that the patient has a 10 days history. Yes, so just notice this. Please notice this. The diphtheria usually has a very acute presentation, whereas infectious mononucleosis, it has a long incubation period, and following incubation period also the patient does not usually acutely present. Second, the patient is not very toxic in infectious mononucleosis as he is in diphtheria. And here, an important thing is given here, that is in splenomegaly. Yes, splenomegaly is a very important feature of infectious mononucleosis. Here the liver enzymes are deranged. So after spleen, later on what is involved is also the liver. So all these things are pointing. So can you see that whenever all this is in your mind, just a simple CBC, complete blood count, can help you to come to such an important diagnosis. Yes, and along with complete blood count, you are going to get the liver function, the renal function, and that is for all the infections that we are suspecting. We get all these tests done to find out what it is. So how are you going to manage this patient, infectious mononucleosis? How do you manage infectious mononucleosis? Yes, for management of infectious mononucleosis, do we give antibiotic? No, this is a viral condition, so we are going to give, yes, no antibiotic. You are just going to give supportive management. And if the patient, yes, tell me what the management is. Yes, I'm waiting for your answer. Yes, you give supportive management, and if the patient does not benefit, if the patient goes into respiratory distress, then you can go for steroids. So either supportive management or steroids. So yes, this is the typical appearance that you see in infectious mononucleosis. The tonsils are enlarged, all congestion, and this petechiae. Petechiae is, yes, it is not very specific to infectious mononucleosis, but yes, this is an important finding that we see in some cases of infectious mononucleosis. So sometimes in your question it is given petechiae is present, yes, on the soft palate. So that also indicates infectious mononucleosis. Yes, we give symptomatic treatment. So coming to the next question, so what we are seeing is that when there is any condition of the oropharynx, this is how you are going to approach. The abscesses you will be able to find out just by inspection. The other conditions like diphtheria, you can take a swab, but if it is, you have to find the immunization history. If it is infectious mononucleosis, leukocytosis, agranulocytosis, all that you can find out by just a CBC examination. So that is what you're going to do next. If there's suspicion of bacteria, if the immunization history is not there or incomplete immunization history, the first thing you're going to suspect is diphtheria. And that is a repeated question of your exam. So always remember, yes. So the symptoms are very general, whether it is corona, whether it is diphtheria, whether it is infectious mononucleosis, sore throat, pain throat, difficulty in swallowing, there can be dyspnea, yes. So all fever, acute onset fever. So this is how you come to a diagnosis. Okay, so yes, a 6-year-old child presented to the OPD with a complaint of bilateral nasal obstruction, nasal discharge, mouth breathing, snoring for the past 1 year. Okay, so there is a 1 year history. There is a history of 2 episodes of pain in the ear in the past 4 months for which he took treatment. His teacher has asked for checkup as he is not responding to her commands and falling asleep in the class for the past 1 week. So yes, what is your most probable diagnosis? Most likely diagnosis is? Yes, this is very good. Yes, yes, there is nasal obstruction, nasal discharge. Yes, very good. This is adenoid hypertrophy. I can see all of you are giving me the answer. This is the adenoid hypertrophy. What's the difference between adenoid hypertrophy and adenoiditis? I can see some of you are marking as adenoiditis. Yes, adenoiditis is acute infection of the adenoid. There the patient will present with fever, acute onset fever, along with all these conditions. Here it is just a hypertrophy. Whenever there is any mass in the nasopharynx, we know it will obstruct both the nose, it will obstruct the eustachian tube, and it will cause difficulty in speaking and breathing. So there will be, what's the type of voice that is caused by adenoid hypertrophy known as? Type of voice is rhinolalia, rhinolalia clausa or aperta. Is it rhinolalia clausa or is it aperta? Adenoid hypertrophy leads to clausa or aperta. Yes, I am waiting for your answer. Anurag, Rashmi, Palak, Anu, what will be the voice, type of voice in adenoid hypertrophy? Rhinolalia or rhinolalia clausa or rhinolalia aperta? Aperta or clausa? Yes, because of obstruction, nasopharynx is closed, so it is rhinolalia clausa. Yes, so yes, because of nasal nose symptoms are given nasal obstruction, nasal discharge. He is not breathing through the nose, so he is doing mouth breathing. He is not able to breathe properly. There is obstruction, so there is snoring. There is recurrent acute infection of the ear, acute otitis media. He is not responding to the command because he is not hearing. Because of which condition of the ear? Which condition of the ear? Yes, very good. Because of serous otitis media. And he is falling asleep. Why is he falling asleep? Because he is not able to sleep properly at night. So there is serous otitis. There is sleep apnea. There is sleep apnea. Okay, so how will you confirm your diagnosis? So this is in your mind that this is the patient of adenoid hypertrophy. So this is the child who has come to you. Parents have come to you. 1 साल से नाक बंद रहती है. जब देखो नाक बहती रहती है. मुंह खोल के सांस लेता है. You ask him more history, कान में का भी दर्द होता है, सुनाई ठीक देता है, why have you come? टीचर ने बोला है सुन नहीं रहा है आजकल, सो जाता है क्लास में. So all these tell you that this can be adenoid. Yes, so how are you going to confirm that this is adenoid? Will any blood test confirm that this is adenoid? Or what will you go for? How will you confirm that this is? Yes, will you go for laryngoscopy or endoscopy? Yes, Yes, I think you mean it is nasal endoscopy, no? Yes, yes, you can go for nasal endoscopy. Posterior rhinoscopy, tell me, will you go for posterior rhinoscopy or not? This is a child, 6-year-old child. 6-year-old child, will he allow you to do a posterior rhinoscopy? No, he will not allow. You will ask him to open his mouth and put the posterior rhinoscopy mirror from behind. He will run away. You can examine the nasopharynx by posterior rhinoscopic mirror, but in a small child it will not be able to do posterior rhinoscopy. Nasal endoscopy, yes, nasal endoscopy can be done. X-ray can be done. Now what is the advantage of nasal endoscopy? The advantage of nasal endoscopy and the disadvantage of X-ray is that in X-ray you are exposing the child, is a small child, you are exposing him to radiation. In nasal endoscopy you are not exposing him to radiation. Whereas what is the benefit of X-ray over nasal endoscopy? X-ray is easier to do in such a small child. Nasal endoscopy, we will have to anesthetize the nose. So either can be done, X-ray can be done or nasal endoscopy can be done. And again here, endoscopic grading. Endoscopic grading. What is endoscopic grading? This is what many of you ask me, that how do we grade? This was asked in our viva, that how do you grade when you see the by endoscope? Again, it is very easy. Grade 1 is it is occupying 1/3 of the nasopharynx. 2 is 2/3 of the nasopharynx. 3 is more than 2/3. 2 complete, yes, 1/3 to 2/3. Okay, 1/3 to 2/3 is 2. 3 is more than 2/3 to nearly complete obstruction, to nearly complete. Okay, not complete, nearly complete. And 4 is total obstruction, complete obstruction. So this is how endoscopically you grade it. And so you see that yes, it is enlarged adenoid. How are you going to manage this patient? How are you going to manage this patient? So it is very easy to remember. 1 is 1/3, 2 is up till 2/3, 3 is more than 2/3 to complete obstruction, and 4 is complete obstruction. How are you going to manage? Now by X-ray you have diagnosed that this is a patient of adenoid hypertrophy. Should we pose the patient immediately for adenoidectomy, or will you like to give some medical management to the patient? What will you like to give? Immediately pose the patient for adenoidectomy or some medical management. See, it is given here that he has been troubled for the past 1 year, but he has taken treatment only for pain in the ear. And right now also he has come because the teacher is complaining. Will you like to go for some medical management? Yes, you will like to go for medical management. What medical management will you give him? Will you give him antibiotics? Yes or no? No, this is the hypertrophy adenoid. You are going to give everything to decrease the size of adenoid. And how can we do that? We are going to do that by, yes, with the help of nasal steroid sprays. So you are going to give the patient nasal steroid sprays. There can be allergic hypertrophy of the adenoid. So you are going to give anti-allergics. And how long are you going to give the management for? What will you tell the patient? Will you like to get a tympanometry done? Yes or no? Yes, you will like to get a tympanometry done for ruling out a serositis media. So you are going to give the medical management for how much? Yes, for how long will you give the medical management? Yes, for 3 months. Do we know that anything more than 3 months we call as chronic? Yes, so you will give the medical management for 3 months. If it does not benefit, then you are going to go for adenoidectomy. Yes, so what is the important pre-op evaluation that you will do? And these are some very important questions that are asked from you. That you are posting the child, you have decided that you will post the child for adenoidectomy. What is the important evaluation that you will do for the child? Yes, and all this might look very simple to you. That is what you do in every patient that you are going to go for a surgery. Do you get the bleeding, bleeding to testing for whether the bleeding time, clotting time is normal or not, the coagulation time is normal or not? Yes, here it is very important, because you are going to approach an area which is blind, which is behind. If there is bleeding, you will not be able to notice. So these are some things which are very important. You should know. This is a child that you're operating on GA. So the teeth should not be, if the teeth are shaking, you have to get it removed prior, so you don't have to dislodge the teeth, and that can lead to obstruction. You have to rule out a cleft palate before operating. Why do you rule out a cleft palate before operating? Very good. Yes, you rule out a velopharyngeal insufficiency, because if there is a cleft palate and you remove the adenoid before the before, when there is adenoid, the features of cleft palate, nasal regurgitation of food, the rhinolalia aperta, all this will not be obvious, but once you have removed the adenoid, they will be obvious. Craniofacial abnormality, Down syndrome, all these you need to rule out. Yes, so why do you need to rule out a Down syndrome? Craniofacial abnormality. Have you heard of Gristle syndrome? Gristle? What is Gristle? What is gristle? Yes, in the post-operative period, because you're operating on that area of the posterior pharyngeal wall where we have the vertebrae present. So because of inflammatory edema, there is atlantoaxial subluxation, following which the child will have torticollis, difficulty, painful movement of the neck. So if there is a craniofacial abnormality, if there is Down syndrome, the chances of Gristle syndrome is increased. So that is why you have to be very careful while you're operating these kids. Yes, so now quickly let us come to, yes, what you have told me. You have asked me to do the procedure along with the instruments along with that. So quickly we will have a brush up of the yes, position. So that was one query that many of you asked me, that we are not able to clearly understand the difference between the roses position and between the boys position. Okay, now what, just imagine, okay, now you are this, you are not going to rectify, not you're going to just whatever I'm going to say, you are going to just keep it in your mind. You are going to think about this, what I'm going to ask you, you're going to think about it. Now this is the first picture. In this, the patient is lying down. In this patient, suppose you want to operate on the tonsil, this area. Okay, you want to operate on the tonsil area or the adenoid area. Okay, just forget everything, just place this patient. I've told you that I want to operate on the tonsil or on the adenoid or maybe on the trachea. Yes, so place this patient, put the position. So will you raise the head of the patient? See, what are the options? The options are, either we can keep him straight, his head straight. Second is, we can raise the head of the patient. Second, or we can extend the head of the patient. We can extend it. Okay, so if we raise the head of the patient, what will happen? If you raise the head of the patient, you are operating in this area, you are operating on the adenoid area. What will happen? Bleeding, when it will occur, it will go into the esophagus, it will go into the hypopharynx so easily, and you will not be able to notice. Because of gravity, it will drain very easily. If we place him straight, again it will go very easily. So we want this in a dependent position. We want this area in a dependent position, so that whatever blood bleeding is occur, because this is not a skin that you are operating, this is not something outside that you are operating, that if bleeding occurs, if all the bleeding occurs, the patient will swallow, and it is a child that we are operating on. So there the blood volume reduces immediately. So yes, we want it in extended position. Have you got it? Yes, so we want it in extended position, so that the blood does not track down, the child does not go on repeatedly swallowing the blood. So that is why we will extend. Yes, can you see here, extend? We are going to just extend the neck. So when we extend, how are we going to extend? We are going to put something just behind the shoulder. So now what happens is that the trachea comes at a higher position and this comes in a lower position. So now just see this picture. This is the second picture. See the third picture. Can you see the third picture? Now if you're going to do tracheostomy in this patient lying in the position number 1, can you see how difficult it will be to localize the trachea? Whereas in picture 3, can you see the trachea? The larynx is almost so visible and so prominent. So whenever you want and this is the emergency surgery that you are doing, the tracheostomy. So if you want to open the trachea, it is so easy when the trachea is so prominent, when the larynx is so prominent. You can do it very easily, you can feel the landmarks very easily, and you can open the trachea without damaging the adjacent structures. Yes, so that is why either for adenoidectomy or tonsillectomy or for tracheostomy, this is the position. In this position, many of you ask me that is this hyperextension? No, this is not hyperextension. This is extension at the cervicothoracic joint. This is the cervicothoracic joint, that is the neck cervical, and it is extension at the atlanto-occipital joint. It is extension at both. It is not hyperextension, it is extension at two joints, these two joints. Okay, so now what we do is, now if we want, now take the second scenario where we want to approach the where we want to operate on the larynx. Okay, so we have the larynx here, or we want to operate on the bronchus. Okay, so we want to operate on the larynx or the bronchus, we want to approach it. Now the long axis of the larynx and the bronchus is like this, whereas the long axis of the oral cavity is like this. So how from here am I able to pass a endoscopes? All the endoscopes are straight, they are not curved like that. Yes, so how are you going to pass it? The bronchoscope, yes, how are you going to pass it? Like this. So yes, for that we want to bring the oral cavity in the line. Yes, we want to bring the axis of the oral cavity in this line, for which we will have to raise the head. We will have to raise the head. We will have to only raise the head. Yes, you just need to raise the head. You do not need to do anything else. Yes, so we have raised the head. So what has happened is that the axis of the oral cavity has come in the axis of the larynx and the trachea. So we have just raised the head and extended the head so that we can this oral cavity can come in this line. So this is what we are doing is, we are extension at the atlanto-occipital joint, whereas we have not done anything to this. We have, when we raise, automatically this cervicothoracic joint gets flexed. Is it clear? It gets flexed. So this is what is the Boyce position. This is the Boyce position. Okay, so this is what we are going to do whenever we are going to do a bronchoscopy, or this is how you intubate the patient. Direct laryngoscopy, or whenever you intubate the patient, this is how you do that. Okay, so now quickly let us come to the instruments for tonsillectomy, and these are the instruments that are asked from you. Like in this year also in AIMS, there was one instrument that was given and you were supposed to identify the instrument. So we will have a quick brush up just in 5 minutes of the instruments used in adenoid and tonsillectomy. So the first important thing is that we want the mouth of the child to be open. We want the mouth of the child to be open, so that we and we do not want to our hands to be engaged in opening the child. So we want some instrument so that the mouth is open automatically, and the instrument keeps the mouth open. So we are using this tongue blade. This is the tongue depressor, which will keep the tongue down, the jaw pushed down, and this is which is going to pull the teeth up, keep the mouth open. This is in the form of a D. Can you see? It looks like D. It looks like D. This is known as Davis. This is Davis, and this is the Boyles. So it is known as Boyles Davis. Boyles Davis. So this so this tongue blade is engaged in this Davis. You are asked which is Boyles and which is Davis. So this is Davis, D is Davis, this is Boyles. We engage it, and this is how we are going to place it. Yes, are you seeing this? That we have placed the tongue, we have depressed. Sometimes there is fenestra in this tongue blade present, and that is for the endoscope. This is for the intubation tube to pass, so that the intubation tube does not get pressed. And this is for the tongue. So can you see that when this is placed against the tongue, if the teeth are shaking, they can come out, and parents are going to ask you after that my child, where is the teeth was there, now where is the teeth? Yes, and also there can be aspiration of the teeth. So you have to ask about the teeth, whether it is shaking or not. So this is how we have opened it. Open the mouth. Yes, this now once you just place this by opening the mouth, this can move here and there. This can just move and here and there. This needs to be fixed in this position only, so that it does not come out. When we touch it, it does not move and it does not come out. So that we are going to do with the help of this instrument. This is known as Draffin's bipod stand, and this is attached to a plate. So just see how we are going to, yes, the surgeon sits on the head end and just see how it is fixed. Now can you see that this thing, the Boyce Davis mouth gag, it is fixed to this. The mouth is open and it is placed inside this Draffin's bipod. So, and this Draffin's bipod is fixed, it is standing here, which is fixed to this blade. This blade, there are openings here, it is fixed, so it cannot move. So this whole setup becomes a totally immobile setup, and the mouth is kept open. Now whatever even you manipulate inside, this is going to be like this only. It is not going to move unless and until you move it. Okay, so first, yes, another question that is asked in your exam: when you have to do a adenoidectomy as well as tonsillectomy, what do you operate first? Whether you go for adenoidectomy first or a tonsillectomy first, we always go for adenoidectomy first. Why adenoidectomy first? Because that is the area where if the bleeding occurs, we are not able to see. So what oropharynx tonsil area, we will be able to see the bleeding. So we remove the adenoid and we put a nasopharyngeal pack there. And by the time after that we do the tonsillectomy, and by the time we have removed the tonsil, there is enough, so much of time have passed that once we remove the nasal pack, the nasopharyngeal pack, we will be able to see whether there is bleeding or not. So if it is totally dry, we know that that area there is no more bleeding occurring. So this is what is St. Clairs Thompson adenoid curette. This is how it looks like. This one is without guard and this one is with guard and with cage. Yes. So this is how we hold this. These are the questions that are asked in your exam. You hold it like a dagger. You pass it behind the uvula. You engage the adenoid in the adenoid curette, and with the help of sweeping movements, you do not have to force it forcefully, you do not have to do sweeping movements. So with light sweeping movements, you have to remove the adenoid, you have to scrape off the adenoid, and here you have to take care not to injure the eustachian tube openings which are laterally, so you do not have to go very laterally. So you scrape off the adenoid. Previously it used to be just a blind procedure. Nowadays we are doing it with the help of visualization under endoscope. So we pass endoscope either through the oral cavity behind the palate. The 70 degrees endoscope is passed here. The 70 degrees endoscope is passed here. So we will be able to visualize this, or we can pass the endoscope through the nose and we can visualize doing this. The instruments that we are using nowadays can be either a curette. Curette is a cold or a hot method. Curette is a cold method. Cold means that heat is not produced. So whenever we are cutting, we are using a knife. What is that? That is a cold method. Again, that is a question of your exam. Cold method. You can use micro debrider. As I have told you, what is micro debrider? It is like a shaver. It is like a shaver. It has got a blade which rotates at a very high speed and it takes off all the tissue very quickly. It eats up all the tissue very quickly. So we can use a micro debrider. We can use, yes, this is under endoscopic visualization. Micro debrider is being used. Micro debrider again will be a cold method. Yes, you can also do it with the help of a mirror, visualization under a mirror. Yes, so you can do it with the help of micro debrider. You can also do with the help of coblation. Yes, now again this was a doubt which many of you were asking. Coblation. Coblation is coagulation along with ablation. Is this a hot or a cold method? Please see, this is a hot method. This is a hot method. This is radio frequency ablation. Here the heat that is produced is very little as compared to laser. But this is as compared to laser or as compared to cautery. But this is a hot method. It produces coblation. It produces coagulation because of heat, radio frequency. Yes, so these are the instruments that we are using in the nasopharynx to remove the adenoid. We do not use laser. Laser is not used. Laser is not used because it will lead to a lot of charring and it will lead to the eustachian tube area will get narrowed. Nasopharynx is already a narrow area, so there can be further narrowing of the nasopharynx. So laser is not used here. Okay, so now, yes, these two important, very important thing in the post-op. Again, that is a question that is asked very commonly. What are the important things if you're doing only adenoidectomy, you're not doing tonsillectomy. Okay, so you have placed the pack there. You have to count the pack. Why is it very important? Because the moment the patient comes back to normal, you have removed the moment you remove the endotracheal tube and put his head in the normal position, in the flex position. Now, what will happen? That pack will directly fall down into the larynx. It will lead to laryngeal obstruction, and the patient will go into stridor. He can also die because of obstruction. And the same is with, you need to suction that area very, very nicely before removing the intubation tube, because if there is any clot, a big clot there, the moment the patient flexes the head, the clot will fall down and obstruct the larynx. That is what is known as coronus clot, and that can lead to sudden death. That can lead to sudden death. You have operated so beautifully, and following surgery there can be sudden death because of that. The most common complication, yes, is hemorrhage. Okay, now the same is for tonsillectomy. Tonsillectomy, again, the Boyce-Davis mouth gag is put and it is fixed with Jaffin's bipod, as we can see. Can you see here? Can you see here? There are holes here in this plate, and this bipod is fixed inside, so now this cannot move. Okay, so the first step is you pull out the tonsil. You pull the tonsil medially. This is medially, this is laterally. So you're pulling the tonsil medially. This instrument that you pull the tonsil with is a very important question of your exam. This is what is known as Dennis Brown tonsil holding forceps. And whenever you are asked first to identify, second to differentiate this forceps from this forceps. Yes, are both of them looking the same? Very much the same? Yes, both all of them are looking very much the same. So that is why it is asked in your exam, what is this and what is this? Yes. So the Dennis Brown tonsil holding forceps has to be differentiated from this forceps, which is known as Lux forceps. This is known as Lux forceps. So what is the difference between them? Yes, first see the joint. Can you see the joint here? Can you see the joint of Dennis Brown? This is a box joint. This is the first thing that you need to see. Second, you are going to hold the tonsil. Yes, we know that tonsil is very vascular. So we do not want the ends of this forceps to be very sharp. If they are very sharp, what will happen? It will cut through the tonsil. We are holding the tonsil and we are pulling it medially. We are applying pressure. We do not want it to cut through the tonsil and remove the tonsil chunk along with it. So this is blunt. This has got blunt. You will feel it. When you feel it, it is totally blunt. Whereas, just see the Lux forceps. Lux forceps, this joint, can you see? This is a screw joint, and this has got very sharp edges. Yes. And here in yes. So first identify this. What is this now? Tell me, is this Lux or is this tonsil? This is Dennis Brown tonsil holding forceps. Is this Lux or is this Dennis Brown tonsil holding forceps? Yes, just see here. Yes, there is a box joint. Yes, this you will not be able to feel. Yes, whether it is when you're seeing in the picture. So how, by seeing the picture, you can find out this is tonsil holding forceps and this is not Lux? Yes, can you see? One is smaller, the other is bigger. Yes, so the smaller one, can you see it fits into the bigger? It fits in the bigger. It has to hold. The smaller one fits into the bigger, and always there is a gap here because of this box joint. So whereas this Lux is equal size, both of them are equal in size. So this is how you are going to differentiate a Lux from a tonsil holding forceps. So you have held the tonsil medially. You have dissected. What is the plane of dissection? The plane of dissection is lateral to the capsule. Yes. So again, here there are two important things. When you are doing it with microdebrider, you can just eat the tissue. You can just make the blade cut the tissue, and leave the capsule behind. When you leave the capsule behind, that is what is known as intracapsular tonsillectomy. Whereas if you remove along with the capsule, that is what is known as extracapsular tonsillectomy. Extracapsular, you have removed the capsule also. Intracapsular is done only when the tonsils are hypertrophied for sleep apnea. When you are operating for sleep apnea, only then you remove the excess of the tonsil. Otherwise, for all infective conditions, you have to remove the complete tonsil along with the capsule. So the plane of operation will be lateral to the capsule. When you are operating, this is known as dissection method. Dissection and snare method, the plane is lateral to the capsule, that is in the loose alar tissue lateral to the capsule of tonsil, in between the capsule and the superior constrictor. So now you have dissected everything. Now only the pole of the tonsil is left, so that you engage. Yes, now see this instrument. This is known as the tonsillar snare. It has got a wire here, and in this we put the thumb inside here, and the middle finger and the index finger we put here, and what we do is we engage the base of the tonsil in this snare, and we press it. So when we press it, what happens is this goes inside. This goes inside, cutting as well as crushing. Cutting as well as crushing the tonsillar base. Why is crushing also important here? Crushing is also important here because the base of the tonsil is where the arterial supply of the tonsil enters it. So we crush it so that the hemostasis is achieved. Okay, now once we have removed the tonsil, now we want to inspect for bleeding. So for looking for bleeding, we use a instrument like this. Just see this instrument. One end is curved like this. Yes, that is this end. This is known as a retractor. This is known as retractor. Yes, the end is this is known as retractor. As you can see here, this will be able to retract the anterior pillar. So we want to see the tonsillar fossa, so we will retract the anterior pillar, and this is known as dissector. So the dissection in the plane of the tonsil is done with the help of the dissector. So we will retract and see, and if yes, this is the various other methods by which tonsillectomy can be done. Microdebrider. So first was the dissection and snare method. This one is microdebrider, where you are seeing that the blade is moving very quickly, eating up all the tonsil. Quickly tell me the dissection method, the microdebrider. Is this cold or hot? This is cold or hot? Yes. Now, yes, Nikhil is asking me that can the same snare be used for polypectomy? It used to be used for polypectomy of the nose, yes. Nowadays, polypectomy is not done. We know that, no? Nowadays, when we have to remove the polyp of the nose, what do? We remove the polyp of the nose by FES. Nowadays, polypectomy is not done in the nose. We do FES, endoscopic sinus surgery. Okay, so yes, this is cold. Yes, very good. Yes, this is cold method. Harmonic scalpel. This is a scalpel, as this is a blade which vibrates at a very high frequency, and that causes the dissection in this plane. Again, this is a cold method. This is a blade that we are using. It is vibrating at a very high frequency. That is again a cold method. Now, cautery or coblation or laser, all that is hot method. Coblation, we can see coblation. What is coblation? Coagulation, we can see the coagulation is occurring, as well as ablation is occurring, as well as tonsil is getting removed, and the hemostasis is being achieved at the same time. This is what is coblation. Radio frequency ablation is done here. So coblation is also a hot method of removal. Yes, so cold method is cold knife, microdebrider, harmonic scalpel, or cryosurgery. Hot is cautery, coblation, and laser. Now again, in cautery is asked what type of cautery do you use here? Prefer. Is it bipolar or unipolar? Always both can be used, but what is preferred if you do is bipolar? Always bipolar is preferred. Okay, so now by chance you spot area that is bleeding. How do you hold it? So that is by this forceps. This is known as tonsil artery forceps. If you would have normally seen the artery forceps are either straight or they are curved, but very little. Okay, they are very little usually. If you see such a artery forceps which is curved so much, can you see it is curved so much? This is a tonsillar artery forceps. Also, the normal artery forceps that we see are smaller in size, whereas the tonsils, because we have to pass it from the oral cavity into the oropharynx, they are quite big in size. So this is how we use both the We use, this is the bleeding vessel, okay, this is the bleeding vessel. We hold it with a straight forceps, and then we pass the curved artery below it, and we pass a suture below this. We tie it. So we pass a suture around this, we tie it, and when we tie it, as we are tightening it, once we have tightened it around this, we remove this. So ultimately what happens is that this is the straight forceps, and this is the tissue, the artery that we want to ligate. So we have tied the knot. Below this, the knot comes. This is something like this. Yes, so we pass the yes, below this, and now what happens is that the hemostasis, the artery is now in the knot. Now this is, you must be thinking that why not just pass the needle and tie it? No, that is not possible in the tonsillar fossa. We do not pass a needle, and it is not possible to pass the needle and tie. This is the procedure of tying a bleeding area of the tonsil. And we know that tonsillectomy, bleeding is, hemorrhage is the most common complication. Hemorrhage following tonsillectomy is most commonly arterial or venous? Arterial or venous? Yes, it is venous. Which vein? External palatine vein, that is also known as the paratonsillar vein. Yes, paratonsillar vein or the external palatine vein. So this is how, once we have ligated also, we again inspect with the help of the retractor. We inspect the tonsillar fossa area. We put the packs there, and once we are sure that no bleeding is occurring, no active bleeding is occurring, then only then we extubate the patient. So these were the few instruments that we need to know in the tonsil and the adenoid. And yes, these are the instruments that are asked very commonly in your exams. So I hope you are doing all the questions from the book. Yes, and don't ever lose hope any time. I know sometimes it is difficult to keep yourself motivated, but measure your success every day. See where you're going every day, and always remember that you have reached this place, you have reached till here after a lot of effort that you have put in, after a lot of effort that people that love you have put in. So don't ever give up. Don't ever give up. If you feel that this path is appearing blocked, find a new way. Find a new way. Go around the block and find your path, but don't give up. So that was what we needed to know in the condition of oropharynx, how we manage the conditions of oropharynx. And in the next lecture, we are going to start with the nose. So in the nose, we will start with first the sinusitis. Yes. So we will do the clinical discussion of sinusitis, nasal polyps, yes, polyps and sinusitis. So that is what we are going to do next. If you have any suggestions, please you can put in the comments below, and all your suggestions are most welcome, and that helps me to improve and know what exactly you need. So all the best, God bless you, and take good care of yourself. Keep your immunity good, have proper sleep, and don't worry about anything at all. So love you all.